So I was asking how important it is to educate the family, not just the patient, because this diet, exercise is so much bound to family dynamics. Is it?
Absolutely. I think very, very important. I think that is also one of the most crux of diabetes management. It goes two ways. One is the patient is very protective of the family is very protective of the patient. So they'll say, doctor, don't give many medicines. Or they will say, doctor, why can't he eat a little sweet? So that is where it is important to educate the family. So we say, this is a healthy diet. It's not like only because he has diabetes he should take. The whole family should follow the same diet. And when you're talking diet, whether you are a child or a middle-aged or an older person, the temptation is the same, right? So if there is going to be an unhealthy food like a sweet or a savory, like mixture in the house, there is going to be the patient going to take it. So there should not be all of these things, which is not good for anybody. So if that concept is understood by the patient and the family, that we are not denying him anything, we are just taking him back to maybe 30 years or 20 years back when there was healthy food. Where was this culture of eating masala dosa on every weekend or going to hotel on weekend or making sweets? Now sweets are so easily available. Again with your cell phone you could have a dining out or dining in or bringing in. Food comes in all the time.
And in Indian culture, some sweets were specific for those days itself,
Exactly.
isn't it? Only Diwali would make those kajai and all those
Yes.
things. Now whenever you want to get kajai.
Yes, exactly. When we were small, only Deepavali, Krishna Jayanti somewhere.
Ganesha festival alone, you get that modak.
Yes. Now through the year it is available. I had the other day a young girl of about 14 years. I see her mother was saying she eats too much pizza. And I was like, she said, no doc, I very rarely eat it. I said, what is your definition of rare? She said, only 3 times a week. So that is where even definitions are changing. I don't eat every day, I eat rarely. So this is again counseling for the whole family. The other reasoning is that they should understand that it's not the question of less medicines. This usually comes when insulin is introduced, saying don't give insulin, doctor. Then they are scared about that. But we want glucose control because we know with the evidence that only glucose control can prevent complications of diabetes. So if you look at any problem today, whether it's heart or kidney or anything, or infection, even fevers are more common in diabetics because your immunity is low and you get disorders very faster. So we have to counsel them that sugar control is good, and unless the sugar control is good, all these problems will happen. So that is where education comes in to the family member as far as diet is concerned, encouraging exercise as well as stress control, understanding what is the stress for that person. Sometimes it is family stress also. So dealing with it in every which way with the family. And the other point I would like to talk about is type 1 diabetes. So a child of 4 years getting diabetes and the two being on insulin pricks, you can understand how traumatic it is for the patients.
Absolutely.
Patients, parents.
Yes.
Patient doesn't know, he's 4 years, he'll be running here and there, taking 3 times a day injection happily. But the mother breaks down and the father breaks down. So I will usually call them in separately and tell them, see, in front of the child, you are a superman or a superwoman. You can't break down because the child only understands their emotions and saying, okay, I have a grave problem that it's making my parents who are so strong break down for this. So those are reflected emotions which can cause a lot of turmoil. So yes, family support in their food habits, encouraging them to get good sugars are very important in any chronic disorder control.
So education, lifestyle changes is one part of diabetes management.
Yes.
Coming to medication itself, what is available now and what has changed over the last 30 years?
So earlier we had only sulfonylurea, metformin. And the two we had glibenclamide. I think now glibenclamide is not available in most countries. So that was the first generation sulfonylurea. Then now, of course, we have safer sulfonylurias. Post that, we had some basic insulins. I still remember the purified insulins or the human insulin, which we had to give for my grandmother who was diabetic, used to come from Singapore. We never had it in India. So from there, we have indeed come a very, very long way. We have safer, better medicines. Now, how did these medicines come? Why the numbers have increased is earlier we thought the pathophysiology, which means the cause or mechanism of diabetes, was only twofold. You have insulin, it doesn't work for you, and you have insulin which becomes very less for you from the pancreas. So we had drug which makes the insulin work better, that is metformin, and we had a tablet, sulfonylurea, which increased insulin secretion from pancreas. Now we have 8 different mechanisms. We know now that there are 8 and many more mechanisms by which someone becomes diabetic. So each of these mechanisms have been developed into a drug molecule. So the newer drugs today, we have SGLT2 inhibitors. So I won't go into much detail, but basically those are drugs which inhibit the reabsorption of glucose at the level of the kidney, and they excrete glucose. So they have found to be good for the heart and kidney, not only for sugar control, so wherein they are also being given for non-diabetics, for kidney and heart, because they are good for that also. So earlier, sugar medicine means it should control sugar. Now not like that. Sugar medicine should control sugar, it should be safe for the kidney and heart, but also should improve them if possible, and of course not cause low sugar, does not cause weight gain, because these are the other 2 things that we are very worried about. Low sugar is something we are all morbidly afraid of, whether it's a patient or the doctor, because you can have seizures, you can become unconscious, and your quality of life, which is a very another important part of any chronic disorder, is also hampered because you're tired with low sugars, there are lots of ups and downs. So that is something which is we want to avoid. So now the newer drugs are aimed at all of these things. They won't put on weight, they may lose weight, or they will, and they are beneficial for the kidney and the heart. So these are the newer molecules we are having. As far as injectables, we always have the good old insulin, which is by far the best treatment when everything else fails. And then of course we have recently the injectables, because with the epidemic of obesity happening, we have now GLP-1 analogs, which help not only in glucose control, in weight control also. And we have a combination of GLP-1 and GIP, which is tirzepatide. Then we have semaglutide. So I think we have a whole list of drugs with us compared to 30 years back when we didn't have many drugs.
Yeah. How do you choose amongst these drugs?
So every drug has its mechanism of action, and every patient who's sitting in front of us is unique. So for that patient, which of these molecules suits best, that is what we should see, assess, and prescribe. There is no one treatment fits all. So it is very, very individualistic to a patient. Of course, there are very many guidelines. If the patient has this, you do this. If he's overweight, you give this. And there are broad guidelines. But still, the patient coming to you is unique, and you need to be aware of that. And it's designer prescriptions, if I should say so.
So there are set parameters which you...
Yes, there are parameters which you have to follow broadly. But they are broad guidelines. Like, what are guidelines? You and I know they are basically so that the whole population of doctors know exactly what to do. But you are the best judge sitting in front as an endocrinologist. You are the best judge what the patient needs in front of you, right? So let's say, for an example, in the guideline, it is if the patient is obese, of course the starting drug is always metformin. You can add an SGLT2 or a GLP-1. Supposing you have not taken a good history, patient has recurrent urinary tract infection, and you give him this SGLT2, he will get more urinary tract infection. So that guideline will change a little bit. So depending on the patient sitting in front of you and what his needs are, then you adjust your treatment accordingly. Yeah.
Interesting. Now, one more thing, or the saying or knowledge is that eventually you'll end up with having insulin. Is that true?
So that is the dictum, they say, that after so many years of diabetes, invariably you will need insulin because all other medication will not work. So today, earlier that number of years was 8 to 10 years, but now with the advent of so much medication, it has gone to 14, 15, 16 years. But there is a population of patients, maybe genetic, who don't need insulin. They are well controlled with tablets itself for as long as they live. And there's a population within 1 year or 2 years, they need insulin. Depends on the breakdown of the islet cells, possibly, and that may be genetic. But by and large, yes, to a large extent now, they are controlled with OADs, oral antidiabetics, and later on, much later on, they may need insulin.
End up with some insulin.
Yeah.
That is the fear what people have, isn't it? Having to use injectables.
So this is something again which you asked me, what is the myth to demystify? This is one of the myths, injectable. Injectable because it's a protein, right? It's just one another treatment, and tomorrow we will get inhaled insulins, we'll get oral insulins. So, and the prick today, we have the pens, and we have such small needles that it's so easy to take. In fact, when I was doing my DM program, it was must for us to inject ourselves once to see how painful it is. So it is absolutely not painful. So when I'm telling you, let's say you're a patient and I say it's not painful, I should be convinced it's not painful. True. Otherwise, I don't know if it's painful or not. I can't tell you something, right? So yes, I have taken a prick and it is not painful. So it's first the mindset and the fear. So the fear for the patient is he has seen his ancestors, mother, maybe parents or grandparents, they started insulin in their end when they were having some serious problem, or their quality of life went down because we didn't have such good insulins at that time. So that memory makes him scared. Many times I have patients now who start insulin and then I say, okay, do you want to go back now? Your glucose is good. Do you want to go back to tablet? No, doc, my quality of life is much better. I will continue with insulin. So it's the initial fear of a prick. But once they get used to it and they find it so good and easy to control, then definitely their acceptance becomes much better.
And what are the newer developments in insulin treatment itself? I've heard about these pumps, which can last longer. You don't need regular pricks and things like that. What are the advances now? So
actually, the main advances that have happened in diabetes is one is the monitoring system. Earlier, when I started, people used to do either fasting or they used to do postprandial. They will not do both together. They say, you have fasting, why? So it was such a big problem for us to convince we need both. Then what used to happen, the patients fasting people very good control, but we used to admit them for some reason and the night insulin sugars used to be very high. Then we realized that the morning is not reflective of the evening glucose and all that. So then we got into testing more often by home blood glucose monitoring, which we call SMBG, of self-monitoring of blood glucose. Usage of glucometers became more frequent. Testing became more frequent. People could do it at their house. And this is something which I'm very particular about, that they should test at home, because in the lab it's very specific. They're waiting for the technician either to come home or they're going to a lab. So their food, that's the biggest problem. They'll have their food in the nearby hotel. What did you eat? I ate idli vada. Which sugar will not go high if you eat idli vada, you tell me. So I said, no, you're supposed to eat whatever you make at home. So now with the onset of glucometers, they're testing at home, they're just testing at different times of the day. And of course now we have CGM, which is continuous glucose monitoring, which is just a small sensor, which is like a 10 rupee coin, which is just attached to your upper arm, and your sugars will be you can monitor your sugar control and you can see how the control is, and accordingly your treatment can change based on the glucose values. That is one advancement from going to lab. Then we had glucometers. Now we have called CGM, which is the continuous glucose monitoring. The next improvement is insulin delivery. The delivery systems have changed. Earlier we used to have only that 40 IU needles. You know, earlier when I was doing my MBBS, we used to have syringes, glass syringes. We used to boil them, you know, and reuse them. So those days went, thank God for it. number of sepsis we used to find because of that was huge. Now we have disposable syringes, which are much more better. Then we moved on to the pens, and then, like you said, we have now the insulin pump. The insulin pump, unfortunately, in our country is not affordable for many and may not be so required also. But that is a device which has a syringe which has insulin also. So you have to just plan your insulin dosage and pump it into the pump or enter it into the pump, and that will deliver it more physiologically. The insulin in the body, how it's secreted is, it's a basal rate. That is secreted every minute, one small dose will come. That's a basal. Then you have some bolus, that as soon as you eat, the carbohydrate enters and triggers off glucose. So that's called the bolus insulins. So we can mimic that to a large extent with the pump. Unfortunately, affordability is not so, it's a very expensive problem. So that is in insulin delivery. We had syringe, then we had a better syringe and better needles, then we had pens, and now of course we have pump. Then coming to insulin itself. So basically earlier we had bovine insulins, then we had porcine insulins, now we have human synthetic insulins, which are from DNA. And so these insulins are more physiological. The duration of action is very much like what is the insulin secreted in our body. So we have small short-acting insulins, we have long-acting insulin, and we have mixed insulin, which is a combination of the short end. So they are their duration and the way they work are much more physiological than what we had. So advantage of this is there's less low sugar, better flatter control of glucose, and not much of ups and downs. We call them peaks and valleys. Those things are avoided, but nothing we can do without patient's control.
Very true.
And cooperation, yeah.
True. So now the patient's diagnosed with diabetes and they've done all the lifestyle changes. Now they're eating healthy, exercising, still they're progressing with their blood sugar control. So they're on insulin. What is the next step? Would they still go into complications in spite of all this good control? So what is the complication rate?
So that's a very, very interesting and important question. So like we discussed first, the complications of diabetes are divided into two, micro and macro. Micro means eyes, kidney and nerves to a large extent. So that can be almost 100% prevented with good glycemic control from day one. It has memory also. Let's say you were badly controlled. That memory is there. If you have good control from day one, yes, to 100% you can prevent eye problem, kidney problem. But there's a small genetic element. Even if your sugars are good, if you're highly prone for kidney disease, then there's a chance you may get. But to a large extent, if you say run of the mill, you can prevent eye disease and kidney disease and even nerve disease. But there's one more factor which we call macrovascular. That is the heart attacks or myocardial infarction, strokes, which is cerebrovascular accidents. There's many other associations. There are other risk factors, stress, cholesterol, blood pressure, gender. All of these are also factors which influence a heart attack or a stroke. So all of that also should be controlled along with blood glucose to prevent. So those are the problems that we are not able to prevent largely just by sugar control. So yes, though he is well controlled now, his risk of macrovascular complications or other cardiovascular complications are still there.
That still stays.
Yes,
and the microvascular things
you can prevent to a large extent.
100%.
100%, yes.
So that is encouraging.
Yes, yes.